Hello and welcome. Today we're breaking down the brand new 2024 KDIGO Clinical Practice Guideline for Chronic Kidney Disease. And trust me, this is a big one. It's packed with major shifts in thinking for everyone from primary care to specialty practice. So let's get right into it.
So let's start with this number, just to set the stage. 850 million. That's the estimated number of people worldwide living with some form of kidney disease. To put that in perspective, that's more than double the number of people with diabetes. It's just a staggering figure. This isn't some niche condition. It's a full-blown global health crisis that we're all seeing in our clinics every single day. So, the big question for all of us is, what does this massive number mean for that one patient sitting in the exam room with you? And more importantly, what can we do to fundamentally change their path? Well, that's what this explainer is all about, giving you the key, actionable updates from the new guideline to do exactly that.
You know, the guideline really reframes how we should think about CKD. It's not just a condition. It's this ongoing imbalance between what the kidneys can do and what the body is asking them to do. Think of it like this. CKD is often a vicious cycle. Some initial injury knocks out a bunch of nephrons for good. The remaining healthy ones? They have to work overtime. They hyperfilter to pick up the slack. But that very compensation, that metabolic overload, is what ends up damaging them over the long haul, creating this downward spiral. Our entire goal is to find a way to break that cycle.
And that brings us to our first big mandate, and this is aimed squarely at my colleagues in primary care. Because CKD is so quiet in its early stages, the power to really change outcomes starts with you, and it all begins with detection. For so many years, we've all relied pretty heavily on eGFR, but the 2024 guideline makes it absolutely crystal clear. eGFR by itself is not enough. It's kind of like trying to assess a patient's heart risk by only checking their blood pressure and completely ignoring their cholesterol. So the new, undeniable standard of care for screening, for staging, for prognosis is the dual measurement of both eGFR and the urine albumin to creatinine ratio, the ACR. And the best part is, the guideline makes this super straightforward to actually do. It's a really simple two-step process. First, you start with an easy, random, untimed urine ACR. No special timing needed. If that first screen comes back at 30 milligrams per gram or higher, you just confirm it. Get a follow-up test using a first morning void sample. That's it. It's a very efficient, low-hassle way to find that clinically significant albuminuria. Now, to make meeting this new standard even easier, point-of-care testing is a total game-changer for the primary care office. Think about it. You get rid of the sample transport, you get results for both creatinine and ACR right there during the visit, and you can make treatment decisions on the spot. This kind of convenience could have a massive impact on our early diagnosis rates.
Okay, so you've detected CKD. What's next? Well, in primary care, our role then shifts from just screening to proactive management. And that really means two things: accurately predicting your patient's future risk, and then using this powerful new arsenal of protective therapies we now have. This KDIGO heat map is basically your clinical GPS. It's a fantastic visual that shows you exactly how eGFR and albuminuria work together to place your patient's risk of progression, cardiovascular events, and even mortality. You can look at it and immediately see if your patient is in a low, moderate, high, or, and this is key, a very high-risk category. That then tells you how aggressively you need to monitor and treat them. But we can actually get even more specific than just these broad risk categories. The guidelines are now strongly recommending that for patients in stages G3 to G5, we should be using validated risk equations to figure out their absolute risk of kidney failure over a certain period of time. It's about getting a much more personalized prognosis.
And the best tool we've got for this is the Kidney Failure Risk Equation, or KFRE. I mean, its accuracy is incredible. It's been validated in millions of people all over the world. And this isn't just an academic tool. It has very direct clinical uses. For instance, if you calculate a 5-year risk of kidney failure that's somewhere between 3 and 5%, that's a clear trigger. It's time to refer to nephrology.
Okay, this is where things get really exciting. We are truly in a new era for managing CKD. The pillars of therapy are so much more than just RAS inhibitors now. We're talking about SGLT2 inhibitors, non-steroidal MRAs like finerenone, and GLP-1 receptor agonists. And listen, these aren't just for diabetes anymore. They have proven profound benefits for slowing down CKD progression and cutting cardiovascular risk. They are the new foundation of care for so many of our CKD patients. All right, I want to shift gears a little bit here and speak directly to my colleagues in palliative and supportive care, and really to anyone who's managing patients with advanced kidney disease. Because as we all focus on the labs and the risk scores, we can never, ever lose sight of the person who is living with this disease day in and day out.
This chart from the guideline is such a powerful reminder of what our patients are going through. The symptom burden in advanced CKD is just immense. We're talking about crushing fatigue, chronic pain, a debilitating itch. These are not just side notes on a chart. They are central to the patient's daily life. And here's the crucial point. Managing these symptoms isn't secondary to managing their GFR. It is a primary goal of care.
The guideline gives us some really clear, evidence-based strategies for this, but it's not a one-person job. Managing these symptoms takes a holistic, team-based approach. It's about combining things like exercise and better sleep hygiene with very targeted medical treatments. This is all about the team focusing together on one thing: improving that patient's quality of life.
And let's be really clear on this point. Supportive care is not the same as end-of-life care. It is an ongoing process that should start early, and it should run in parallel with all the other disease-modifying treatments. The whole focus is on the patient's quality of life and on supporting their family, no matter what their prognosis or treatment path looks like.
A huge part of this is proactive advanced care planning. We have to be the ones to start these conversations, and we have to start them early and keep having them. This means talking honestly about prognosis, taking the time to truly understand what matters most to the patient, and making sure that every single decision, whether it's about starting kidney replacement therapy or even stopping dialysis, is perfectly in line with their personal values and goals.
And really, this brings us to the core message of the entire guideline. We have to bring these different perspectives together. The real power here isn't in separating these roles of primary care and specialty care, but in weaving them together into one seamless journey of care for our patients.
So let's just boil it all down. For my primary care colleagues, the mission is clear. Switch to dual marker screening with eGFR and ACR. Use risk equations like the KFRE to personalize care and know when to refer. And get comfortable using these new protective therapies early on. And for my palliative care colleagues, get involved early. Focus on aggressive symptom management and make advanced care planning a continuous, patient-led conversation from the get-go.
And that really leaves us with one final, crucial question. We now have the knowledge, with the tools to dramatically change the lives of people with chronic kidney disease. The challenge ahead of us now is to build the actual systems of care that make this integrated, proactive, and compassionate approach the absolute standard for every single patient, right from day one. Thank you for joining me for this explainer.